When you think about fixing a leaky pipe in a house, I mean, the logical thing to do is just go right to the pipe itself, right?
Right, exactly. You just, patch the leak.
Yeah, or you widen the pipe to relieve the pressure or whatever.
Uh,
And, well, historically, we've treated the human cardiovascular system in a very similar way.
oh, absolutely. It makes mechanical sense on the surface.
Right. Like, if your blood pressure is too high, it feels like a plumbing problem. You just need a drug that relaxes the blood vessels directly. Widen the pipes, the pressure drops, it's clean, it's intuitive.
It is. I mean, for decades, the prevailing logic in medicine was just to treat the symptom exactly where it physically manifests. So if the pressure in the vessel is high, well, target the vessel.
But then you look at a stack of pharmacology research, like the sources we have today for this deep dive, and you realize the body isn't just a simple plumbing system.
No, not at all. It's way more complex.
It's basically a highly networked electrical grid. So today, we are skipping the pipes entirely. We're going to figure out how a couple of accidental discoveries managed to hack the brain's master control board to turn down the pressure.
Yeah, we're looking at a class of drugs called central alpha agonists. Specifically, we're focusing on two flagship molecules, which are clonidine and methyldopa.
And bypassing the physical blood vessels and going straight to the brainstem, I mean, that is an incredibly elegant, if somewhat dangerous way to approach the human body.
It really is. It's a total paradigm shift from just fixing the pipes.
And that is our mission for this deep dive.
Yeah.
You and I are going to unpack these sources to help you, the listener, understand the mechanics of this brain hack.
We've got a lot to cover. Medical mysteries, counterfeit molecules, and a few side effects that completely mirror an illicit drug overdose.
It gets wild. But to start, we really have to talk about why the name of these drugs confuses medical students everywhere. They are called alpha agonists.
Right, which is inherently confusing.
Totally. Now, if you, the listener, have ever had a terrible cold and taken an over-the-counter nasal decongestant, something like phenylephrine,
Okay.
you have taken an alpha agonist.
Which, ironically, does the exact opposite of what you'd want for high blood pressure.
Exactly.
Because in the periphery of your body, like your arms, your legs, your nasal passages, an alpha agonist tells blood vessels to constrict.
It clamps down on the pipes.
Right. It clamps down to stop your nose from running. And as a byproduct of clamping those pipes, it actually raises your overall blood pressure.
Which creates a massive paradox. Because clonidine and methyldopa are alpha agonists, but they dramatically lower blood pressure.
Yeah, they do the exact opposite.
So calling these drugs alpha agonists is like, I don't know, calling a tool a screwdriver when you actually use it to hammer in a nail. The name implies one action, but the result is entirely different.
That's a good way to put it.
But why? Because you were using it in a different room of the house. You're using it in the brain.
Exactly. The location basically changes the entire function of the receptor.
Okay, let's unpack this. How does it get there?
Well, these specific drugs are uniquely structured to cross the blood-brain barrier. They don't just linger in the peripheral blood vessels.
Right.
They travel deep inside the brain to the brainstem. And the brainstem is essentially the body's master regulator for autonomic functions.
And the sources mention two critical areas down there, right?
Yeah, the NTS, which is the nucleus tractus solitarius, and the RVLM, the rostral ventrolateral medulla.
So if I'm picturing this, the NTS is kind of like the sensor array, and the RVLM is the command center.
Yeah, that's a great way to map it. The NTS is just constantly taking in data from sensors all over your body. It's reading your current blood pressure.
Okay.
Then it relays that data to the RDLM, which acts as the outgoing command center. So the RVLM sends electrical signals down your spinal cord to your sympathetic nervous system.
And just so we're completely clear on the jargon here, the sympathetic nervous system is our fight-or-flight network, right?
Correct. And it runs on what we call sympathetic tone.
Like a baseline hum.
Exactly. It's the baseline hum of activity, keeping your heart beating and your blood vessels slightly tense. And the chemical messengers that carry this signal are called catecholamines.
Okay, like adrenaline.
Yeah, adrenaline and norepinephrine are the famous ones. When the brainstem fires its signal, the body releases norepinephrine, which speeds up your heart and constricts your vessels.
Okay, I follow the electrical pathway. So the brainstem sends the signal, norepinephrine gets released, blood pressure goes up. But where do these drugs actually fit in?
Well, they target a specific receptor called alpha-2, which sits directly on those neurons in the brainstem. But here's the twist. Alpha-2 isn't a gas pedal, it's the brakes.
Wait, hold on. Alpha-1 in my nose constricts vessels, but alpha-2 in my brain acts as a brake pedal.
Yeah, nature loves a negative feedback loop. So normally when the body has released enough norepinephrine to raise your blood pressure, some of that excess norepinephrine binds to these alpha-2 receptors on the very neuron that released it.
Oh, wow.
It's the body's way of saying, message received, we have enough pressure, shut down the signal.
So when a patient takes Clonidine, the drug is basically manually pressing that brake pedal.
Exactly. It's tricking the brainstem into thinking there's way too much norepinephrine out there, even if there isn't.
So the brainstem hits the brakes, sends out less traffic, your heart rate slows down, the vessels relax, and the blood pressure drops.
Right. You are overriding the system at its source. It's kind of like pharmacological biohacking.
See, a mechanism this precise like hijacking the brain's internal feedback loop, it sounds like the result of some billion-dollar, decades-long targeted engineering project.
You would think so.
But the sources reveal they figured this out entirely by accident. They had no idea they were hacking the brainstem.
It's true. The history of pharmacology is littered with brilliant accidents, but, these two drugs really take the prize. They were the right drugs for completely the wrong reasons.
Right. Let's look at methyldopa first. Merck developed it in the early 1960s. And at the time, they were operating on the peripheral depletion theory.
Yeah, the logic was pretty straightforward back then.
Basically, if norepinephrine causes high blood pressure, let's just starve the body of the raw materials needed to make it. So they designed methyldopa to block an enzyme called dopa decarboxylase, effectively stopping the assembly line.
Which sounds good on paper.
Yeah. They give it to patients, the blood pressure drops, and they celebrate. But wait, if they were totally wrong about the mechanism, why did the blood pressure actually drop?
Because of what the body did to the drug once it was ingested. See, methyldopa is a prodrug.
Meaning it's not active right away.
Right. On its own, in the pill form, it isn't the active agent. It has to be metabolized by the body first. So it gets absorbed, enters the noradrenergic neurons, and the body's own enzymes grab it.
Okay.
But instead of the drug just blocking the assembly line like they thought, the enzymes actually manufacture a brand new molecule out of the drug.
Right. A molecule called alpha-methylnorepinephrine.
Exactly.
So the neuron is basically tricked into manufacturing a counterfeit chemical.
Counterfeit is the perfect word for it. In pharmacology, it's known as a false neurotransmitter. The neuron stores this fake molecule right alongside the real norepinephrine.
Wow.
And when the brainstem fires its electrical signal, the neuron releases this counterfeit version into the synapse.
Wait, but if the body releases a fake neurotransmitter, wouldn't that just cause a misfire? Like putting the wrong fuel in a car or something? Why doesn't the system just stall out?
Because this particular counterfeit key happens to fit perfectly into the ignition, but it's designed to turn the car off.
I see.
That fake neurotransmitter is a highly potent alpha-2 agonist. It actually has a much stronger affinity for the brake pedal than the natural neurotransmitter does.
That's crazy.
And even better, the body's natural cleanup enzymes don't break it down as easily, so it sits on the brake pedal longer and pushes it way harder.
That is just wild. The body literally takes the raw materials in the pill, builds its own biological brake fluid, and shuts itself down.
It really is an incredible mechanism.
Yeah. But, the origin story for Clonidine might actually be crazier.
Yeah.
Synthesized in the 1960s by Boehringer Ingelheim. And they weren't even trying to cure high blood pressure, were they?
Not at all. They were just trying to make a topical nasal decongestant.
Which goes back to the whole alpha agonist thing. They saw the chemical structure, an imidazoline compound, an alpha agonist, and just assumed it would clamp down the peripheral vessels in the nose and clear your sinuses.
Yeah, that was the assumption.
But during human testing, the patients didn't just get clearer sinuses, they got profoundly drowsy, and their blood pressure plummeted.
Right, which is not what you want from a nasal spray.
No. So normally, a drug company scraps a failed decongestant that makes people pass out. Why pivot to hypertension?
Well, the clinical observations demanded it. When pharmacologists saw that profound drowsiness, they realized their peripheral vessel theory was dead.
Because drowsiness means it's hitting the brain.
Exactly. Drowsiness proves the drug is crossing the blood-brain barrier and acting on the central nervous system. They basically had to reverse engineer their own accidental creation.
So they traced the molecule's path.
Yeah, eventually locating those alpha-2 receptors in the brainstem.
Yeah.
It forced a massive paradigm shift in cardiology, going from looking exclusively at the pipes to actually examining the central control board.
And since we're hacking the brainstem, how do doctors use this today?
Yeah.
Because the sources show some incredibly elegant, clinical applications where doctors use this physiology not just to treat a disease, but to solve diagnostic puzzles.
Oh, absolutely. The clonidine suppression test is the classic example of diagnostic elegance. You aren't just lowering a number on a monitor,
Right.
you are manipulating a specific neurological pathway to essentially ask the body a question.
Okay, let's lay this out for the listener. Say you have a patient with dangerously high blood pressure, and their blood is flooded with catecholamines, those fight or flight hormones.
Oh,
The doctor needs to know, is the patient's brainstem just hyperactive, or do they have a rare, dangerous adrenal tumor called a pheochromocytoma?
because that tumor acts like a rogue factory, just pumping out hormones autonomously.
Exactly. So what does this mean for you, the patient? It means the doctor can actually use a dose of clonidine as a biological wiretap.
It's like a live inpatient pharmacology experiment. You give the patient clonidine, and we know clonidine pushes the brake pedal in the brainstem.
Right.
So if the patient's blood pressure and plasma hormone levels drop, the test is negative for a tumor.
Oh, I get it. Because it tells you the brainstem was driving the high blood pressure, and the clonidine successfully told it to stop.
Exactly. The central brakes still work.
It's basically like flipping the master breaker switch in your house to see if a particular light bulb goes out. If you flip the master switch and that light bulb stays on,
Then you know it's wired to a completely different power source. Yeah, if you give clonidine and absolutely nothing happens, you know the brainstem isn't in control. The tumor is acting independently, just dumping hormones without answering to the central nervous system.
the drug proves exactly where the dangerous signal is coming from. That is brilliant.
It really is.
And we also see methyldopa used with similar elegance, specifically in obstetrics. For decades, methyldopa was the absolute go-to first-line drug for pregnant women with high blood pressure.
Yep, the gold standard.
But what surprised me in the sources is that they explicitly state it wasn't because it was some miracle drug that worked better than anything else.
No, its efficacy was totally standard. What elevated it was its unparalleled observational safety record.
Right, because researchers tracked children born to mothers who took methyldopa during pregnancy. They followed these kids for years.
Yeah, one major program tracked developmental milestones up to 7.5 years of age.
And they found no developmental harm attributable to the drug. I mean, in an era where almost every new medication carries theoretical risks for a fetus, that accumulated real-world data was priceless.
It's a crucial lesson in medical practice, honestly. First-line status isn't always awarded to the newest, shiniest, or most powerful molecule.
Sometimes it's just about trust.
Exactly. Often it goes to the drug with the heaviest weight of accumulated safety data. You trust what you know doesn't cause harm.
And on the flip side, we also see clonidine being used off-label in ways entirely unrelated to chronic blood pressure.
Oh, yeah, like in addiction medicine.
Right. Addiction clinics use it for opioid withdrawal. They give a blood pressure pill to calm the sweating, the racing heart, the severe agitation of withdrawal. But why does that actually work? Like, what's the overlap between an opioid and a blood pressure medication?
Well, it comes down to a tiny cluster of neurons in the brainstem called the locus coeruleus.
Okay, the locus coeruleus.
It's essentially the brain's main alarm system for panic and alertness. And opioids, they suppress this alarm center.
So it keeps it quiet.
Right. But when a person is dependent on opioids and suddenly stops taking them, that alarm system just wakes up and hyperfires, causing all those brutal withdrawal symptoms.
So it's a massive sympathetic nervous system overload.
Exactly. And because clonidine targets alpha-2 receptors, which are also heavily present in that alarm center, it acts as a sort of surrogate suppressor.
Oh, wow.
Yeah, it steps through a side door and artificially hits the snooze button on the locus coeruleus, quieting down the stress response even when the opioids are gone.
But, I mean, tinkering with the master control board of the brain's sympathetic system has to come with severe risks, right?
Of course.
If you're artificially holding down the brakes all the time, the body doesn't just sit there passively. It adapts.
Yeah, the nervous system constantly seeks homeostasis. So if you constantly flood the brainstem with clonidine, the body basically says, there's way too much pressure on the brake pedal. We don't need all these receptors.
So it gets rid of them.
Yeah, it actually removes some of them. It's a process called downregulation. It re-equilibrates its sympathetic tone around this suppressed baseline.
Okay, so if the brain removes its own natural brake pedals because the drug is doing all the work, what happens if a patient suddenly stops taking their clonidine? Let's say they miss a pill or they wear one of those transdermal clonidine patches and it just falls off in the shower unnoticed.
You trigger a violent withdrawal phenomenon known as rebound hypertension.
That sounds bad.
It's very bad. The sudden removal of that central inhibition leaves the brainstem with literally no brakes at all. It floods the body with norepinephrine.
Oh, no.
Yeah, the blood pressure can shoot up well above what it was before the patient ever started the medication. It can potentially provoke a full-blown hypertensive emergency.
So to be clear for the listener, this isn't just a side effect of taking the drug. This is a violent reaction to the absence of the drug.
Yes, exactly. That's why Clonidine must always be carefully tapered down. Anesthesiologists actually actively fear this. Yeah, before a major surgery, they will specifically interview patients to ensure their Clonidine schedule isn't accidentally interrupted while they are fasting in the hospital.
Because a rebound sympathetic surge while under anesthesia is like a nightmare scenario.
Complete nightmare.
That is terrifying. And speaking of terrifying, the sources highlight a massive public health concern with Clonidine in pediatrics. Because, Clonidine pills are tiny and the patches look like little stickers.
Right, so to a toddler, they look like candy or a toy.
Exactly. And because Clonidine is such a potent central nervous system depressant, accidental poisoning in a small child is a recognized critical toxicological emergency.
It really is.
The sources outline what a toddler overdose looks like in the ER. And it's a profound aha moment because it ties right back to what we just talked about with the locus coeruleus.
The symptoms overlap perfectly.
Right. A child overdosing on Clonidine presents with profound sedation, slow breathing, pinpoint pupils, and a dangerously low heart rate. It perfectly mimics an opioid overdose.
The clinical presentation is nearly indistinguishable. When emergency room doctors are evaluating an unresponsive toddler with pinpoint pupils, Clonidine toxicity is drilled into them as a differential diagnosis.
Because both opioids and alpha-2 agonists suppress the exact same central arousal pathways.
Exactly, leading to the exact same vital sign collapse. In fact, doctors will often administer naloxone, the opioid reversal drug, just to rule opioids out before confirming it's Clonidine.
Wow, it really proves how deeply interconnected these suppression pathways are. Now, methyldopa has its own dark side that caused it to fall out of favor over the decades. Aside from liver toxicity, there is this strange autoimmune reaction.
Yeah, this one is fascinating, but dangerous.
The sources say long-term users can develop what they call a positive direct Coombs test. What exactly does that mean?
It means the immune system is misidentifying the body's own red blood cells as foreign invaders.
Wait, really?
Yeah. Methyldopa, over time, can subtly alter the surface antigens on red blood cells. So the immune system scans the cell, doesn't recognize the altered surface, and produces antibodies to coat and target it.
So the drug tricks the body into marking its own blood cells for destruction.
Yes, leading to autoimmune hemolytic anemia.
That's awful.
Now, only a small fraction of patients progress to active hemolysis, where the cells are actually destroyed, but the mere risk of triggering an autoimmune cascade is significant.
I can see why.
Between that, the hepatotoxicity, and the profound sedation, methyldopa's use outside of pregnancy has just shrunk dramatically over the years.
Which brings us to the evolution of this class of drugs. Because when you have severe side effects like profound sedation, dry mouth, and dangerous rebound hypertension, pharmacologists aren't going to just stop trying.
Right. They wanted to build a better version of the drug,
They wanted a drug that lowers blood pressure without putting the patient to sleep.
which requires isolating the exact neurological switch. You see, the sedation from Clonidine happens because it doesn't just hit the blood pressure centers. As we discussed, it hits the locus coeruleus, the arousal center.
Right.
But researchers discovered that Clonidine was actually interacting with a completely different family of receptors in the brainstem alongside the alpha-2 receptors. These are called imidazoline receptors, specifically the I1 subtype.
Okay, so if Clonidine is hitting both, it's basically like throwing a master switch that turns off the lights in the entire house instead of just the living room.
Exactly. So European pharmacologists developed a second generation of drugs, moxonidine and romenidine, and the explicit goal was to target only the imidazoline I1 receptors.
Hoping to keep the blood pressure drop but shed the sedation.
The holy grail, a brain hack without the sleepiness.
But the sources note they were never actually approved in the U.S., right?
No, they remain unapproved in the United States. They serve as a fascinating historical footnote for American medical students, though, kind of tracking why Clonidine, despite all its messy house-wide side effects, is still the reigning champion in this class stateside.
But the neighborhood of drugs related to this mechanism just keeps expanding. Like you have dexmedetomidine, which the sources call the ICU cousin.
Oh, yeah. Dexmedetomidine is highly selective for alpha-2 receptors, way more selective than clonidine.
So rather than trying to use it as a blood pressure med, they just lean into the sedation and use it for intense, continuous sedation in intensive care units.
Exactly. And then you have guanfacine, same exact receptor target, the alpha-2A receptor, but repurposed entirely for psychiatry. It's used for ADHD to regulate attention and impulse control.
Wait, how does a blood pressure brake pedal cure ADHD?
By acting in a completely different part of the brain. So in the prefrontal cortex, which is the center for executive function, alpha-2 receptors don't regulate blood pressure at all.
Well, they do.
They close specific ion channels on the dendritic spines of neurons. When guanfacine binds there, it essentially cuts out the electrical background noise.
Oh, so it strengthens the network connections.
Yeah, it acts as a signal booster for attention. You are basically enhancing the signal-to-noise ratio in the brain.
That is amazing.
Huh.
And there's also tizanidine, which is used as a muscle relaxant, proving that this receptor's inhibitory reach extends all the way down into the motor neuron circuits in the spine to stop muscle spasms.
It's incredible how one mechanism can be tweaked for blood pressure, ADHD, ICU sedation, and muscle spasms.
It really is. And it contrasts so sharply with the other major class of cardiovascular drugs everyone knows, beta blockers.
Yeah, that contrast is essential for understanding pharmacology. Beta blockers also reduce sympathetic drive, but mechanically they do the exact opposite of central alpha agonists.
Right. The sources lay this out perfectly. Beta blockers block the signal at the destination. They sit directly on the heart muscle and shield it from the norepinephrine. But central alpha agonists turn down the signal at the source, inside the brainstem. So if the sympathetic nervous system is a loud radio broadcast, beta blockers are like putting earplugs in the listener's ears. The music is still playing, you just can't hear it.
That's a great analogy.
But clonidine is like breaking into the radio station itself and turning down the master volume dial.
The volume dial analogy captures it perfectly. And because that volume dial is connected to so many different systems in the brain, well, we get this complex, seemingly messy profile linking blood pressure, alertness, attention, and muscle tone.
We have covered a massive amount of ground today. Let's just recap the critical takeaways from these sources for you. Central alpha-2 agonists like clonidine and methyldopa don't relax blood vessels. They lower blood pressure by hacking the brainstem's outgoing signals.
Right.
They were brilliant accidents, a misunderstood enzyme blocker, and a failed decongestant. They function through counterfeit neurotransmitters and hijacking the body's natural feedback loops.
But they demand immense respect. Because if the body adapts to them and you stop suddenly, you invite dangerous rebound spikes.
Yeah, and in pediatrics, their profound central suppression mimics a terrifying opioid overdose.
Which leaves us with a profound realization about human physiology. Just consider how incredibly efficient the body is at recycling its own biological tools.
It's mind-blowing.
A single receptor mechanism, the alpha-2 brake pedal, regulates blood pressure in the brainstem, it fine-tunes your attention span in the prefrontal cortex, and modulates muscle tone in your spine.
Right.
So when we ingest a chemical, we aren't just targeting a solitary disease in a vacuum. We are dropping a stone into a pond of deeply interconnected neurological circuits. The ripples touch everything.
Dropping a stone into a pond. I love that. That completely reframes how we look at medicine. It's definitely not just fixing the plumbing.
Not at all.
Well, thank you for joining us on this deep dive. The next time you open your medicine cabinet, take a look at those little pills and ask yourself, are these just patching the pipes or are they hacking the radio station? Keep questioning, keep learning, and we will catch you on the next one.